Hey everyone. As nurses, there are few things that demand our full attention and skill quite like caring for a patient with a mood disorder. So today, we're going to break down the absolute essentials of suicide prevention, from what to look for, to the safety plans, to the key interventions that really can save a life. Think of this as your must-know guide. So let's start with the most important thing right up front. When we are caring for a patient with a mood disorder, especially depression, our number one non-negotiable priority is safety, because the single biggest risk we face is suicide, and we have to treat that risk as a medical emergency, period. Okay, so first things first, let's really dig into the stakes here. We're going to explore the why behind our constant vigilance by looking at just how big of an impact these disorders have, and the key factors that put our patients at risk. It's so important to remember that depression isn't just feeling sad. It's a whole body illness. It literally slows everything down. A person's thinking, their ability to concentrate, even their sleep and appetite. It just drains all of their energy and motivation, which of course impacts their physical health, their relationships. It can cripple their ability to just function day to day. And we need to be assessing for all of it. So, who should we be keeping an extra close eye on? Well, there are definitely some key groups. We're talking about older adults, especially those dealing with chronic illness, people with substance use disorders, anyone with a history of trauma or a major loss, and a huge one, individuals who don't have a strong social support system. Each of these is a red flag. And here's the kicker. These risks stack up. The more factors a patient has, the higher our vigilance needs to be. So what's really going on here? Well, it's not just one thing, it's complex. From a biological standpoint, we know there's a connection to neurotransmitter imbalances. We hear a lot about serotonin and dopamine, and of course, genetics can play a big role. But then you have the environmental side of things, like chronic stress, trauma, or huge life changes, that can act as a trigger and either kickstart or worsen a mood disorder. Okay, so now that we know the risks, what do we do about it? This next part is all about assessment. This is our primary role, how we spot the signs and, just as importantly, how we use the right tools to figure out what's really going on. Okay, this slide is awesome because it paints such a clear picture of the two extremes. They're polar opposites. On one side, you have depression, which feels slowed down, heavy, hopeless. A key sign here is anhedonia. That's the inability to feel pleasure in things you used to enjoy. Then on the complete other end of the spectrum, you have mania. It's fast, it's impulsive, it's loud. The person might seem grandiose, have racing thoughts, and show really poor judgment. Knowing these two different pictures is absolutely crucial. Now, this is a really, really important distinction. Suicide risk is not a mood, it's a safety state. This is a full-blown safety emergency. And the signs aren't just about sadness, they're about behavior. A feeling of hopelessness is a massive red flag. So is giving away their most prized possessions. And be especially wary of a sudden, out-of-the-blue sense of calm in someone who has been deeply depressed. It could mean they've made a final decision. Okay, so you're seeing some of these red flags, and your gut is telling you something is off. What's the next step? How do you move from a suspicion to a formal, documented assessment? Well, you need a standardized tool. And that's where the Columbia Suicide Severity Rating Scale, or CSSRS, comes in. I know it looks like a lot, but trust me, the logic is super simple. You start by asking the first two questions about any wishes to be dead or actual suicidal thoughts. Now, if they say no to question 2, the one about having actual thoughts, you can jump ahead to the questions about their behavior. But if it's a yes, you have to continue right down the list to figure out just how serious and immediate the plan is. All right, so you've done your assessment and you've identified a risk. Now what? It's go time. We move immediately into intervention. This is our safety pre-book, the concrete, real-world actions we take to protect our patient. Let's be crystal clear. Priority number 1, above all else, is creating and maintaining a safe environment. Full stop. Every single decision we make from here on out flows from that one principle. So the baseline for a patient who is at risk is 15-minute checks. What does that actually look like? It means a staff member has to physically put their eyes on that patient every 15 minutes around the clock and document where they are and what they're doing. And look, this isn't just about ticking a box. It's also a chance for a brief therapeutic moment of connection. Okay, but what if the risk is a bit higher? We step it up. The next level is line of sight observation. It's exactly what it sounds like. The patient has to be visible to a staff member at all times. They can't just go into their room and shut the door. We have to be able to see them. And then there's the highest level, for when the risk is immediate and severe. That's one-to-one constant observation. This means we assign a dedicated staff member whose only job, their only job, is to be within arm's reach of that patient 24/7. Now, observation is huge, but it's not the whole story. We also have to manage the physical space. That means moving the patient's room close to the nurse's station for easier monitoring. We do a thorough search of their belongings and the room and remove any potential hazards. We're talking sharps, cords, belts, you name it. We also have to watch them take their meds to make sure they're not cheeking them. And this is so important. We have to be brave enough to ask the direct question, are you having thoughts of harming yourself? And of course, you have to document every single check, conversation, and intervention. Okay, we've secured the environment. Now let's switch gears and talk about our medication toolkit. As nurses, it's not about memorizing every single drug out there. It's about knowing the high-yield, absolutely must-know facts so we can give these meds safely. Okay, this chart right here, this is gold. Let's break it down real quick. For SSRIs, a common side effect is sexual dysfunction, but the real emergency to watch for is serotonin syndrome. For SNRIs, think blood pressure. We need a monitor for hypertension. With the older TCAs, you'll see a lot of anticholinergic side effects, but the big danger is cardiac toxicity. And finally, for MAOIs, the cardinal rule is no tyramine foods, things like aged cheeses and cured meats, to prevent a hypertensive crisis. All right, now for mood stabilizers. With these, you have to know the toxicity signs. They're non-negotiable. For lithium, if you see a coarse tremor along with GI issues and confusion, that's an emergency. For valproic acid, we're watching the liver labs. With carbamazepine, a fever or a sore throat could be a sign of agranulocytosis, which is serious. And with lamotrigine, any new rash needs to be reported immediately because of the risk of Stevens-Johnson syndrome. So let's put two of the big ones side by side, serotonin syndrome versus lithium toxicity. Knowing the difference can save a life. Think of serotonin syndrome as being hot and bothered. The patient will have a fever, they'll be sweating, and they'll have hyperreflexia, like clonus. Lithium toxicity, on the other hand, has that classic trio: GI upset, confusion, and a coarse tremor. They present very differently, and recognizing which is vital. Phew. Okay, so we've managed the immediate crisis. But our job isn't done. Not even close. What comes next is all about building long-term stability. This is where we talk about recovery, teamwork, and some of the more advanced treatments that help our patients move forward. This is where we talk about the recovery model, and honestly, this is a total game changer in how we think about mental health care. It's all about being patient-centered. It's not our job to fix the patient. Instead, we empower them to lead their own recovery journey. Hope is the absolute foundation. Our roles shift from being a director to being a partner, a teacher, and a supporter. Now, for some patients, especially with severe treatment-resistant depression, ECT can be an absolute lifeline. And our role as nurses is critical every step of the way. Before the procedure, we're making sure they're NPO, that the consent is signed, and getting all the pre-procedure tasks done. During, we're right there at the head of the bed, monitoring their airway and their vitals. And afterward, safety is everything. We get them into a sideline position, we reorient them as they wake up, and we always check for that gag reflex before they have anything to eat or drink. So I want to leave you with this question to really think about. We know safety checks are vital. We know giving meds is essential. But how can we weave those principles of the recovery model, hope, partnership, empowerment, into those everyday tasks? How can a simple 15-minute check become a true moment of connection? That, right there, is the art of psychiatric nursing.